Yeah, the combination of ibrutinib and obinutuzumab was explored as part of a large French study that was looking at the possibility of frontline options that achieved MRD negativity without the inclusion of chemotherapy drugs, without the inclusion of purine analogs or alkylating agents. So this trial had all patients receive obinutuzumab and ibrutinib in combination at first, with the thought that patients that have detectable disease would then receive standard chemotherapy afterwards with the goal of ultimately achieving MRD negative remissions. They reported on the patients that up till that first endpoint, the combination of ibrutinib and obinutuzumab, they reported also universally successful outcomes as far as response, so the 100% response rate. But they did note that not all patients, or not many patients, achieved that MRD negativity, I think about 10% or so. So they did note that most of the patients still needed to receive chemoimmunotherapy afterwards with the goal of achieving MRD negativity. I do think, though, that the study is still successful in showing the feasibility of that combination, the safety of that combination, and that combination did achieve high response rates.
At the ASH meeting, we had a number of different combinations of drugs put together. We had antibodies put together with single-agent BTK inhibitors, antibodies put together with venetoclax, and then we had a very exciting study from Kerry Rogers and colleagues from The Ohio State University updating their data on the three-drug combination, combining the CD20 antibody obinutuzumab with ibrutinib and venetoclax, a three-drug study for both frontline and relapsed refractory treatment of CLL. This is a phase 1b/2 study. They had originally reported the phase 1b results at the ASH meeting the year before, which defined the dose of venetoclax as 400 milligrams as being a safe dose to use. And in this update at the 2017 ASH meeting, Dr. Rogers presented data on the upfront cohort of 25 patients treated with this three-drug regimen for a chemotherapy-free approach to the initial therapy of CLL. So a very exciting study. They saw generally good tolerability. They started each drug one at a time to try to help tease out the different toxicities and to help reduce the risk of tumor lysis syndrome from the venetoclax. They did see a fair number of infusional-related reactions to the obinutuzumab, and that's the antibody that they started with. We have some data now suggesting that perhaps starting with an ibrutinib-based regimen and then introducing the obinutuzumab might mitigate those infusion reactions a bit. But nonetheless, in general, the tolerability of their approach was quite good. And I think the results were also striking. Nearly all of their patients responded. About half of patients achieved complete remission, and most of those patients actually achieved MRD undetectability, and that's without the need for chemotherapy. So I think it's a very exciting development, but really the key is going to be to know whether these are durable effects. They've designed their regimen to last for about 14 months, so it's certainly nice that it's a time-limited approach. It does not require ongoing maintenance therapy, but we just don't know yet whether those patients are going to relapse shortly after they finish the treatments or whether these may be durable effects like we've seen with the older chemotherapy approaches. Another study that was very exciting at the ASH meeting was from the MD Anderson group presented by Nitin Jain, looking at the combination of ibrutinib and venetoclax, and their study looked both in the frontline setting and the relapsed refractory setting. But I found the results in the frontline cohort to be particularly exciting. All of the patients responded. Their study started with ibrutinib monotherapy, and as expected, despite having good responses, they did not see a lot of complete remissions or MRD undetectability with ibrutinib alone. But when they added in the venetoclax, they saw those complete remissions rates go up quite dramatically, as well as the rates of MRD undetectability, which went as high as 60% in the bone marrow in patients without the need for chemoimmunotherapy. So I think that's a very promising result, and particularly as most of our CLL patients are older and frailer patients and may not tolerate chemotherapy-based regimens, I think what's exciting about Dr. Jain's regimen is that it's something that could be available for most patients with CLL who need treatment. Another study that was presented at the ASH meeting was my own study of ibrutinib with FCR. This is a regimen that's geared more toward the young, fit patients, and so we have to remember that it's only something we could use in a relatively small group of CLL patients. But I think one of the reasons we were particularly excited about our data is that we saw rates of MRD undetectability of around 83% in the bone marrow. And this was across both mutated and unmutated IGHV CLL patients. As far as we know, this is the highest rate of MRD undetectability that's ever been described for a regimen for CLL. And so we think this is a very promising approach for that young, fit population.
So FCR is a very active regimen for patients with CLL. And we've seen from the German trials and the MD Anderson trials that some patients have extremely long remissions following this treatment. However, there are some patients that don't have that remission, that quality of remission, particularly those with unmutated immunoglobulin genes. So based on that, Dr. Davids and his colleagues conducted a multi-center trial to look at the combination of ibrutinib with FCR, regimen they dubbed IFCR. They enrolled patients who were younger, and so the patient population is by definition younger than age 65. Their patients ended up having a fair number of patients with adverse prognostic factors, including a few patients with deletion 17p and more than half of their patients with unmutated immunoglobulin gene. At this past ASH meeting, Dr. Davids presented the results from 35 of his patients. He showed that the response rate was universal. All of his patients responded. Only about a third of them had complete responses, but something that was striking to me was that more than 80% of patients had undetectable residual disease in the bone marrow following treatment. This to me suggests that some of those patients may be able to discontinue treatment and not have immediate relapse, something that we don't expect usually with ibrutinib alone. And at a higher incidence, the number of those patients is higher than we would have expected with FCR alone. I am, I guess, excited to see the full results of his trial. I do know that he's enrolling, or they are enrolling more patients, including a cohort that will stop ibrutinib upon achievement of an MRD negative bone marrow, with the option to resume ibrutinib in the future if the disease recurs. I think studies like this will be very useful for deciding an optimum therapy for our patients in the future.